Hello, everyone, and welcome to our podcast, Gator RX, where we focus on various prescribing topics such as controlled substances. I'm Kirsty Biggs, and I'm joined by my other group members, Ashley Posada and Victoria White. Today's guest speaker is Dr. Jessica Bensick, a pediatric primary care nurse practitioner for 15 years and UF's 2021 Preceptor of the Year. She has also contributed to 3 different textbooks. Dr. Jessica has a long history of working with pediatric patients. In 2005, she graduated from UF with her BSN and began working as a pediatric nurse in the PICU at UF Health Shands Children's Hospital, where she worked for 5 years. While in the unit, she was working and completing her master's degree at UF to be a pediatric nurse practitioner. After graduating as a double gator, she went on to work for Palms Medical Group in Chiefland, Florida, and has been there as an NP for just over 15 years. In 2014, she graduated from Brandman University with her DNP. Her DNP project was published in the Journal of Pediatric Healthcare. It was entitled Pediatric Nurse Practitioner Management of Child Anxiety in a Rural Primary Care Clinic with Evidence-Based COPE Program. I mention this program specifically because Dr. Jessica will discuss the COPE program today with us as it relates to our topic. So today we are going to address a critical issue for adolescents, stimulant use disorder. We will specifically provide evidence-based practice strategies to help make a real difference. We will explore the latest literature on the topic and analyze practical strategies for pediatric primary care providers. So, Dr. Jessica, we're so grateful for your time. Thank you so much for being here today. Before we delve into the evidence, what are your initial thoughts on stimulant use disorder in adolescents? And do you have any particularly impactful stories or experiences that you'd like to share that illustrate the urgency of this issue?
Well, thank you so much for having me and inviting me to your podcast. And I will start off by stating that any mental health disorder has a huge stigma behind it, where that is stigma from family members, the public, social media, anywhere, educational stigmas, or even stigmas within healthcare. And so when we talk about some of the true issues that can come from oftentimes evidence-based treatment of these mental health disorders, specifically stimulant use disorder in regards to ADHD, we have to be mindful that we don't lose sight of the underlying issue of this child or this adolescent or this, young adult is struggling with underlying issues, and because of whatever family genetic history or stressor that person is going through leads to a substance use disorder. So I don't have any specific substance use disorder stories. I manage a large population of ADHD patients. I treat down to 4 years of age within my practice, and then I continue treatment into college till 22 years of age. Not all patients are treated during that lifetime process, but many do need medication on and off with that. Of course, comorbid anxiety and depression will definitely exacerbate risk for substance use disorder, especially as we're trying to self-medicate symptoms that may not be ADHD driven, or we're utilizing other drugs such as marijuana is probably the biggest one that I see within my practice, is a lot of nicotine use disorder and marijuana use disorder.
Well, thank you. That really highlights the complexity of this issue. The statistics are certainly concerning regarding stimulant misuse. According to the Substance Use and Mental Health Services Administration, stimulant misuse in individuals 12 and older is on the rise. And in 2018, a national survey on drug use and health found that 5.1 million people 12 and older misuse prescription stimulants.
So I would like to start by first getting an understanding of the specific vulnerabilities of adolescents regarding stimulant use. The adolescent brain is still developing, particularly the prefrontal cortex, which has to do with decision making. So they are more likely to make risky decisions. This plays a huge role in substance abuse in this age group. Compared to older adults, individuals under the age of 25 are at a higher risk of having a substance use disorder because this age group usually partakes in more risky behavior. Not to mention, in this particular age group, there is immense pressure placed on teens and young adults as they navigate school performance, sports performance, college applications, hormonal changes, friends, peer pressure, relationships, and looking to the future, just like we all have gone through and know is a very stressful situation.
So, Dr. Jessica, what additional risk factors have you seen in practice that we should consider?
So, lots and lots of risk factors that I see. And where I work, especially because it's in such a rural setting, which you all kind of already highlighted, is social isolation and lack of kind of healthy activities that are built into the rural community. There also is a higher concentration of mental health disorders within rural communities. So, if you have a parent and they have who has ADHD and they have a child with another parent that has ADHD, anxiety, and depression, obviously there's a high probability of their child having ADHD as well. And then because they struggle with all these mental health, their parenting skills and their modeling of behavior makes it much more difficult for effective management that will kind of dispel or help that child not struggle with those impulse control or strategies. So that's one of the big risk factors you see. And then you start that at a young childhood, and then they follow that to adolescence. Also, it goes back to that social stigma with looking at how do I put this? Parents, grandparents, great grandparents who don't want medication. And so that child struggles. We get through into our teenage years. They say, hey, take my Adderall, and having kind of a divergent type situation. Here, take this. It'll make you feel better. And it does indeed make them feel better. And then they start exploring because they can't get that Adderall all the time. So then they're going to start dabbling in other drugs, especially marijuana, cocaine, methamphetamines, all of these things that just kind of build up. So I think within the rural setting where I work, especially, you see a lot of that kind of magnified for that. And a lot of people in the rural community smoke and dip from early ages and young ages. So there's a degree of normalcy that the adolescents see. And then you already highlighted the fact is they have no impulse control. So then you have a teenager who already doesn't have impulse control. And then you add ADHD, which caveat is poor impulse control regulation within the DSM-5 criteria. That is just a recipe for disaster when we talk about addiction and drug abuse. Did that answer your question?
Yes, and I have not considered like how the rural population can have different risk factors. So thank you for that.
So I would like to take a moment to discuss the differences between misuse and diversion. Both misuse and diversion are ways in which stimulants are commonly abused. However, there lies a difference between the two regarding what way these medications are abused. So with diversion, it occurs when an individual takes another person's stimulant prescription, whereas misuse is taking a dosage that is higher than what is prescribed to an individual or combining the stimulant with another illicit drug or alcohol to achieve a state of euphoria.
So our group has found a wealth of knowledge on this topic, so let's highlight some key findings to provide some background information. Stimulant use disorder includes stimulant prescription abuse. This literature shows most prescriptions being abused are from family members and friends. As future primary care providers who will care for adolescents, it's crucial that we are able to screen and diagnose non-medical prescription drug use, which includes stimulants such as methylphenidate, amphetamine, and dextroamphetamine. These medications, while essential for treating ADHD, also carry a high risk of misuse. Methylphenidate and amphetamine medications commonly prescribed for pediatric patients with ADHD, and ADHD is a common disorder managed in primary care. However, we need to know how to safely and effectively manage these medications. Some reasons for abusing prescription stimulants include weight control and academic performance. This is essential to address in this population because stimulant misuse is associated with adverse effects and can cause increase in healthcare facility utilization.
So, screening is vital, and to help screen properly, it's essential that we know the risk factors for stimulant use disorder. A recent systematic review found that some of the risk factors include having a GPA less than a 3.5, concurrent abuse of another substance, with alcohol being the most frequently reported concurrent substance at 64.2%. An exploratory study found that there is an increased risk of non-medical prescription drug use for dextroamphetamine, which is Adderall, in boys for sports teams and some individual sports such as lacrosse and wrestling. The American Academy of Pediatrics recommends using the model of screening, brief intervention, and or referral for treatment, which is SBIRT. This is an evidence-based model that recommends universal screening for substance abuse. A validated tool is recommended, and the National Institute on Drug Abuse has 2 online validated tools for the PCP for assessing for substance use disorder risk among adolescents 12 to 17. There is the screening to brief intervention, which is the S2BI, and the brief screener for tobacco, alcohol, and other drugs, BSTAD. So, to Dr. Jessica, what are some of the tools that you use in your practice, and have they effectively identified and screened for stimulant abuse? And have you ever had a situation where this did help you identify a patient who was struggling with this?
Well, thank you for that good question. So, I think screeners are a hallmark in primary care. It is a quick, effective way that you can get information from your patient, usually done in a pre check in type situation. And so, I think, especially with the evolution of EHR systems, we are utilizing a lot of these screeners and assessments, especially that SAMHSA have recommended. Personally, I have never used those 2 brief interventions, but I looked them up and I think they're great. The one that I use instead of from a screening is the assessment one, which is CRAFT, which basically stands for car, relax, alone, forget, friends, and trouble. I almost forgot what it stood for. And I like that screener tool the best. It has great reliability and validity, with initial studies done back in 2002. And then they did updated studies to reassess in regards and overlap to the DSM-5 criteria for substance use and alcohol use disorder. And substances would include stimulants as well to that nature, but they didn't specifically pull out stimulants. They just added that to the mix within the study, for any medication or any substance per se. And it was redone back in 2021 with very good validity. So that is the screening tool I typically use, especially if I have a child who I don't have a rapport with or I don't have a relationship with already. So, because I have had the blessing and the privilege to be within my practice for a lengthy period of time, my original babies are sophomores in high school now. And so many of them I have a long relationship with. So having that verbal discussion is sometimes something I find to be just as helpful as a screening document or an assessment form. Now, if I have a parent who won't leave the room, or it's a child I've never seen, or I don't think this teen is going to be honest with me, I think those forms are a fantastic way for those teens to be able to circle instead of verbalizing concerns or behaviors. Craft also focuses on risky behaviors within the home setting. Have you been in a car with someone who was using too much alcohol? Have you been in a car with someone who was on a substance? So that brings in questions that you can probe. Is this in the household? Do we have a parent? Which would be absolutely a risk factor for that child if you're looking at them from an ADHD standpoint and wanting to put them on a stimulant medication. Are we going to have any divergent behaviors? Are we going to be at risk for a stimulant use disorder that is going on? I have been able to identify a lot of teens and children, well, not children, children like their younger siblings, I should say. So teenagers who have had exposure to these types of substances, whether that's alcohol or Adderall or methamphetamine or marijuana, where they have access within their home setting. And then that helps lead a discussion in addressing those up front and starting that rapport of trust. I always tell my patients, we're in a trust relationship. I'm going to trust you to always tell me the truth and to use your medications appropriately as I prescribe them, and to tell me if you are thinking about or have done any risky behavior. You're going to trust me to make sure I am treating you in an evidence-based fashion, keeping you protected, being on the lookout for warning signs and symptoms, and always reassessing, is this medication doing what we want it to do? Is this still needed? Is there a safer option out there for us? And so having that rapport, and that's where I feel really strongly that ADHD, especially non-complex ADHD, absolutely should be managed in primary care, because they're going to trust you as a pediatric nurse practitioner way more than they're going to trust a psychiatrist that they see once every 3 to 6 months. You are their primary care provider. They trust what comes out of your mouth, and they're not going to want to let you down if you have that trust with them. And so we talk about prevention of risky behaviors. That's going to speak much stronger to that child and preventing that from happening in the adolescent land. Did I address that question?
Yes, thank you so much for sharing your clinical pearls on screening, and we'll definitely have to keep the craft screener tool in our wheelhouse.
Okay, so I would like to quickly shift to protective factors in the COPE program, and how it relates to this topic. Substance use disorder and mental health disorders are considered bidirectional. So adolescents who struggle with anxiety and depression may have substance use disorder or vice versa. One may contribute to and exacerbate the other, but they are often co-occurring. Cognitive behavioral therapy is an evidence-based method that can help children with mental health disorders such as anxiety and depression. Before the development of the COPE program, CBT was typically delivered by a mental health specialist. The COPE program includes components of CBT to help children and adolescents change their negative thoughts to positive thoughts, called cognitive reappraisal. The evidence-based COPE program can help treat children with anxiety and depression. And to become a COPE instructor and do this in the real world, you can actually get trained and immediately implement this evidence-based intervention in the outpatient setting.
So, Dr. Jessica, do you feel like the COPE program may be a protective factor for children and adolescents who may be at risk for developing substance use disorder, such as stimulant use disorder?
So, absolutely. I think that any skills building that we can give teenagers to help them be resilient against all the triggers and the stressors that go on in our adolescent life, that is monumental to that child and monumental to preventing further compounding factors, especially if we're seeing comorbid anxiety, depression, something I always like to highlight, adverse childhood experiences, PTSD, whatever that is that could be compounding that ADHD to where we're going to look and try to self-medicate. This is going to be protective for them because we're working on two pathways. We're working on controlling the inattentive and the hyperactive symptoms with your stimulant, typically. Of course, we can use non-stimulants and other medications, but typically stimulants, which is what we're talking about with stimulant use disorder. But then we're also giving them all these protective skills on reframing the way we approach life. And how can we, encourage ourselves? How can we goal plan? How can we problem solve? How can we boost our self-esteem just by doing these skills that we're going to learn across these 7 sessions. So for the COPE program comes in a child and an adolescent and a young adult version of this. Dr. Melnick, if you ever have a chance to hear Dr. Melnick speak, she is amazing and something I would encourage everybody, if you ever have the opportunity, to go and hear her. But she lost her mom suddenly. She was the only one present in the house. She went upstairs, went back downstairs, and her mom had a brain aneurysm, and she found her dead in the living room. And she then struggled herself with a ton of mental health issues, obviously related back to anxiety, depression, and PTSD, where she was in and out of mental health facilities and pretty substantial. So that brings us to now, where she is a pediatric nurse practitioner, has her PhD, and is a mental health pediatric nurse practitioner. And she looked and said, how can I help them? And so originally, this program started with moms who had babies in the NICU. How can we support these moms who are going through a very stressful situation? And then she took it and said, how can I help adolescents? And actually took it into the public school systems in Arizona to show, and teachers giving this showing success. And then then it was brought into the primary care setting. And that's where I came in. I started it in 2012 doing these programs. I still do them to this day. I think I did 3 this week already. Sessions beginning at age 8, because before the age of 8, they typically cannot understand those cognitive reframing characteristics that we're trying to teach them. And I do it all the way till 22. The Healthy Lifestyles program is the first 7 sessions of the one we do for depression and anxiety, plus an additional 7 after that. So even when we're talking about stimulant use disorder and girls, especially who are using it for obesity, doing that healthy lifestyle 14 session would be very protective in helping boost their self-esteem, changing, saying, yes, my negative thought is, I am fat. I am always going to be fat. How can we restructure that? Well, I really like my hair, or I'm really going to work hard to exercise more, or I know I'm on ADHD medication that helps curb my appetite and increase my metabolism, but I'm going to help it by making good food choices and make sure I take my medicine as directed. So we can work with that teenager to kind of put those protective phrases and thoughts as we go through that program. And especially if you're the provider who is prescribing that stimulant, you can monitor how they think about that as you go through these sessions, because it's great because it's a manual. And so you can talk through any situation. They give a generalized kind of example that anybody can relate to, like Sarah's friends told her her art project looked weird. That made her think that she can't do anything right and didn't talk to anybody in the rest of the day. So we give them a situation like that everybody can kind of relate to. How could Sarah have handled that differently? We give them a skill, and then we say, how can we apply this to you? What are the struggles you're having? And sometimes some of these risky behaviors will come up within that discussion for that. I also feel strongly that when we talk about resilience, which I already spoke on, is we need our teens to be resilient, to be able to have that breakup, to fail that test, to gain some weight, to not be the fastest runner on the track team, but not let that wreck their self-esteem so much that they are trying to self-medicate for whatever pressure, whether that's peer or parental or self-induced. This counseling will help protect all of those items going forward. And that is my plug. Look up COPE, the number 2, Thrive, SAMHSA.org. It's fantastic. I've been doing it for a million years now, I feel like, and I learn something every time I do the session. I hope I answered your question.
Yes, yes, you did. And thank you so much for highlighting all these protective factors that the COPE program provides.
Yes, and then additionally, just to mention another evidence-based guideline that we found from the Substance Abuse and Mental Health Services Administration for the treatment of substance abuse disorders. This guideline recommends a community reinforcement approach for adolescents and involves many components. It focuses on teaching strategies to resist urges and situations that trigger substance use and engaging in new activities and having new social networks that are drug-free. So, with all of that being said, we just want to say thank you so much to Dr. Jessica for sharing your insights with us today. We hope we have provided our listeners with provider actionability for handling this issue and making a positive impact. Dr. Jessica, your real world experiences have been paramount. And to our listeners, our references will be attached to this podcast in the discussion board so you can review these guidelines that we've mentioned at your leisure.
Yes, thank you so much, Dr. Jessica. And for our listeners, don't forget to subscribe to our Gator RX podcast if you enjoyed listening. And next week, we will discuss opioid use disorder. Thank you. You guys have a great day.